Uh, Smoking is one of the major cause of preventable mortality and morbidity worldwide. Based on the NFHS study in 2019 and 2020, overall prevalence of smoking tobacco use in India is 10.38%, and smokeless tobacco usage is about 21.38%. Of all adults, 28.6% persons consume tobacco in smoke or smokeless form, including 42.4% men and 14.12% women. Prevalence of tobacco use in India is very high in northeastern states, and it is higher in rural population than the urban population. As per composition, the composition of the tobacco usage in India is more complex. The chief pharmacologically active components are nicotine, which leads to acute effects, and the tar, which leads to the chronic effects, and other components include carbon monoxide, ammonia, methanol, hexamine, methane, stearic acid, acetic acid, and etc. As everyone knows, smoking leads to um, many disorders from starting from the head to the foot, including all malignancies of the all vital organs. Apart from the malignancies, may also cause um, COPD. It also leads to coronary artery disease and peripheral vascular diseases. Smoking effects on vasculature mainly leads to peripheral vascular disease, mainly in the form of atherosclerosis or thromboangiitis obliterans or aneurysms. Pathophysiology of the smoking, which leads to atherosclerosis, mainly by vasomotor dysfunction. Smoking leads to smoke leads to the alteration in the nitric oxide biosynthesis that leads to the impaired endothelium dependent vasodilatation, and also along with the impaired endothelium dependent vasodilatation, inflammation and leukocyte adhesion and platelet activation leads to the formation of the atheroma. Inflammation, local accruement of leukocytes on the surface of the endothelial cells. Also, smoking increases the release of the pro-inflammatory cytokines like TNF alpha, interleukin 6, and interleukin 3. It also increases the level of the adjacent molecules PCAM1, ICAM1, E-selectin, and P-selectin. Modification of the lipid profile uh, by smoking. Smoking increases the serum cholesterol level, TGL, and the LDL levels, and lowers the HDL levels. The increased LDL and other lipids are undergo oxidative process. So undergo peroxidation that leads to the increased levels of the oxidized LDL, which is scavenged by the macrophages. So from that, foam cells are released, and the foam cells which are released deposited in the endothelium and form the atheroma formation. So other smoking also leads to some genetic predisposition like CYP1, cytochrome A1 MSP polymorphism, or endothelial nitric oxide synthase intron 4 polymorphism, and also some role in atherosclerosis. Smoking also leads to platelet dysfunction in the form of increased activation of the platelets and increased adhesion, and leads to the hyperaggregation. So, as already discussed, in the it's a depiction in the figure where the smoking and atherosclerosis relation, where smoking decreases the nitric oxide synthase activity that leads to the decreased nitric oxide production, and it leads to the increased reactive oxygen species, free radical release, and also endothelial dysfunction, and inflammatory process are increased. Together, they form the atheromatous plaque. Smoking is divided into two: mainstream smoke and side stream smoke. Mainstream smoke is the active smoking, and side stream smoke involves the passive smoking. Active smoking and passive smoking involves the two phases: tar phase and the gas phase. Uh, both the phases leads to the deposition of the nicotine components in the lung, which further increases the free radical release, and also activation of the endogenous sources of the free radicals released by increasing the xanthine oxidase, nitric oxide synthase levels, NADPH oxidases, and also increase the inflammatory process by activation of the neutrophil, monocytes, platelets, and T cells, and all that leads to the oxidative stress and decreased nitric oxide generation or bioavailability, the increased cytokine levels, which leads to vasomotor dysfunction and increased prothrombotic factors like van Willebrand factor, fibrin, and thrombin, and a decrease in the fibrinolytic factors like tissue-plasminogen activator and the tissue-plasminogen activator inhibitor 1. Both are reduced and leads to the increase in plaque formation, the increase in leukocyte and platelet activation, and the increased lipid peroxidation, which leads to increased foam cell deposition, and all and genetic predisposition. All that leads to the formation of the plaque. Smoking and TAO. Uh, in the smoke, three main particles are released: nicotine, carbon monoxide, and carbon dioxide. Nicotine leads to the vasoconstriction of the arteries. Carbon monoxide restricts the lining of the blood vessel, and carbon monoxide decreases the oxygen transport to the tissue. This all together triggers autoimmune response and leads to the TAO. This is interleukin 13 dependent signaling pathway for the which after the smoking there is an increase in level of interleukin 33 from the epithelial cells of the lungs, which uh, through the hepatogenous route enters the blood vessels, and their T cell mediated immune activity is increased. Dendritic cells reduce, T cells are released, which leads to increase in the other inflammatory cytokines, which leads to the vascular endothelial cell injury and finally forms the TAO. Smoking and aneurysms. From the cigarette smoke, it directly leads to the endothelial dysfunction and also the vascular smooth muscle phenotypic modulation. Cigarette smoke also increases the blood volume and increases the viscosity, which leads to the increase in the shear stress in the blood vessels. Along with there is an increase in release of the reactive free radicals, which together leads to the atherosclerotic changes and also the extracellular matrix breakdown and the loss of the endothelial cells and decreased collagen synthesis, all leads to the aneurysm formation, and the finally it leads to rupture. Uh, Environmental factors, atherosclerosis, smoking, inflammation, genetic factors, all uh, increases the elastase activity or decreases the inhibition of the elastase inhibition activity, leads to the elastin degradation and the failure of the elastin, so that there is an increased load on collagen, and there is a increased load on collagen by either through hypertension, aging, all that leads to the failure of the collagen, leads to the aneurysmal dilatation and the rupture. So coming to the smoking cessation therapy, smoking cessation can have positive health effects including an improvement in all-cause mortality. But but the smoking cessation is challenging as it is a complex behavior. It involves both physical addiction and habit. It requires long-term clinical intervention as we do in other addiction disorders. Before that, we have to know about what is nicotine addiction. Nicotine addiction, from the cycle, we know that cigarette smoking leads to the increase in the nicotine spike in blood vessels that travels into the CNS. In that, they activated the nicotinic acetylcholine receptors. When there is an increase in activated nicotine acetylcholine receptors, there is an increased release of the dopamine and other neurotransmitters, which leads to pleasure, mood modulation. This is becomes a conditioned learning, and the smoking continues and the craving increases. Some of the activated neuroendocrine acetylcholine receptors become desensitized. That leads to the acute tolerance. If it is completely inactive, it leads to the decrease in the nicotine levels. That leads to the nicotine withdrawal symptoms. That finally again leads to the craving, and again they start smoking. In simply, nicotine craving cycle is smoke a cigarette, craving will be satisfied. If nicotine wears off, again withdrawal symptoms will develop. That leads to again smoke a cigarette. So tobacco dependence is a two-part problem. So the treatment is based on the um, treatment for the nicotine addiction, the treatment for the habit of using tobacco. Physiological and behavioral therapy both must be needed. Physiological, the addiction to nicotine may be treated by the medications. Behavioral therapy, the treatment involves behavior change program. So what is habit? That is automatic smoking. That is repeatedly pairing smoking with other behaviors and feelings and other moods. So it leads to the engaging in the bad behaviors, which creates unconscious urge to smoke, as in Paulo's phenomenon. Smokers who wish to quit should be managed with a combination of the behavioral therapy and pharmacotherapy, along with as the combination of the counseling and pharmacology therapies produce higher quit ranges than the single. Then first we go to the behavioral change therapy. It includes smoking cessation includes 5 ways. First one is ask first whether to identify who are the smokers. Second one is advise the smokers about the smoking cessation, and assess the patient who are willing to stop smoking. After they giving willingness, assist them to provide a proper quit plan to to add in support groups, and also add pharmacotherapy, and finally arrange for the follow-up. Behavioral change strategies. First, we have to motivate the patient to smoking cessation. Then attempt to smoking cessation. First, we start the nicotine replacement therapy, followed with the sustained motivation, and the further attempt of the cessation of the smoking leads to the final behavioral change. Then we move to pharmacotherapy. The first line drugs are nicotine replacement, either in the form of nicotine gum, inhaler, lozenges, nasal spray, or patch, or oral nicotinic agents in the form of bupropion or varenicline. And second line drugs include clonidine and norepinephrine. So nicotine replacement therapy relieves craving and nicotine withdrawal symptoms while the smoker deals with smoking, breaking their habits around smoking. As already mentioned, the nicotine in cigarettes leads to actual physical dependence. This can cause unpleasant withdrawal symptoms when a person suddenly tries to quit. So that for that, we have to give nicotine in the form of gum, patches, sprays, inhalers or lozenges, which contains only nicotine, but not the other chemicals which was in the other forms of the tobacco. So it can help to relieve some of the physical withdrawal symptoms, so that so that you can focus on the psychological aspects of the quitting. So nicotine replacement therapy, in that the nicotine we provided inhibits the nicotine from the smoke to act on the nicotinic acetylcholine receptors. So and that increases the dopamine levels and maintains the mood level as such when the person smokes. So in the smoke, non-nicotinic compounds is responsible for the most adverse health effects. So it was when nicotine replacement therapy is used, this nicotine is not dangerous, and it will be safer. Benefits of the NRT outweighs the risks, even in smokers with cardiovascular disease. There is a lower risk of dependence compared to the other forms of the tobacco usage. Nicotine is not a significant risk factor for cardiovascular events, even in cardiovascular disease. Nicotine in NRT and also the what is the difference between the nicotine in NRT and the nicotine in smoking. Nicotine in NRT is absorbed more slowly, and it is absorbed by the venous system. No carbon monoxide, no oxidants. There is an attenuated sympathomyotic response, and also the other chemicals which are toxic chemicals present in the smoke was not present. Reasons for using NRT: it works roughly doubling the success rates. It helps the person feel more comfortable, treats the nicotine withdrawal symptoms. It is actually not a treatment in itself, but is intended to complement the other assessments and the treatments provided. NRT should be used in precaution in patients with cardiovascular disease, mainly in the patients with recent MI within the past 2 weeks, arrhythmias, and patients with worsening angina. NRT products may be appropriate for these patients if they are under the medical supervision. So dosing of NRT depends on the number of the cigarettes smoked by the patient. Dose is gradually tapered as nicotine withdrawal symptoms subside. NRT use is generally recommended for the 2 to 3 months after smoking cessation, even though longer periods of time is acceptable in patients with a high risk of relapse. Nicotine gum. Nicotine gum is used for at least 30 minutes until the complete tingling sensation is gone. If the patient smokes less than 25 cigarettes daily, we have to use 2 milligram pieces. If they smoke more than 25 cigarettes daily, we have to use 4 milligram pieces. Smokers should use at least one piece of gum every 1 to 2 hours for the first 6 weeks. The gum should be used up to 12 weeks with no more than 25 pieces of gums per day. And the side effects involves throat and mouth irritation and the increased salivation due to the multiple more than more pieces of gums usage. Nicotine lozenges. If the patient had first cigarette smoke after the 30 minutes of waking from bed, we have to use 2 milligram lozenges. If the patient smokes within 30 minutes after waking from bed, 4 milligram lozenges are preferred. Every lozenges are at least 20 to 30 minutes to dissolve in the mouth. Dosing, at least 9 lozenges per day for the first 6 weeks should be used up to 12 weeks, not more than 20 lozenges per day. Side effects are same as per the gum, like throat and mouth irritation and increased salivation. And also, it should be used in caution with patients with the pharyngitis, esophagitis, and peptic ulcer disease. And next one is nasal spray. It's a direction of use. 50 microliter spray is available, which contain 0.5 milligram of nicotine. One dose is 1 milligram of nicotine, 2 sprays, one in each nostril. Dosing is initially 2 doses per hour, up to 5 doses per hour for 8 weeks, with tapering during the next 4 to 6 weeks. Nasal spray is used in caution in patients with previous allergic nasal disorders or previously bronchospastic diseases. Nasal spray is used in caution. Next one is a transdermal patch. Direction of usage. In this, wear patch for 16 or 24 hours. 24 hours, if the patient had a craving on awakening itself, 24 hours patch is used. Otherwise, we have to remove at the bedtime and apply fresh patch in a clean, non-hairy area of the skin between the neck and waist in the morning. Do not reapply on the same area where the patch already applied for at least 1 week. For patients who smoke more than 10 cigarettes per day, 10-week therapy is recommended. For less than 10 cigarettes per day, 8-week therapy is recommended. Side effects involve mainly skin irritation. Next one is inhalational nicotrol. Direction of the usage, it is available in 10 milligram cartridges. It have to inhale deeply into the back of the throat. Nicotine cartridge is used after 20 minutes of the active puffing. Dosage, it's initial 12 weeks, 6 to 12 cartridges per day. Then gradual reduction of the cartridges during the next 6 to 12 weeks. Side effects involve throat and mouth irritation, rhinitis, sinusitis, and coughing. Next, we go to the non-nicotinic pharmacotherapy. First one is a bupropion. The mechanism of action of the bupropion is it is an inhibitor of the dopamine and noradrenaline reuptake in the CNS level. So decrease in the reuptake leads to the increased dopamine levels in synapse. That gives the similar pleasure effect. So smoking it helps in so in the way it helps in smoking cessation. Dosing is 150 milligram daily for the first 3 days, then 150 milligram BD for the uh, next subsequent days. Treatment should be started even the patient is still smoking, but the target quit date should be within the first 2 weeks of the treatment, and the treatment should be continued for the 7 to 12 weeks. It should be used in combination with NRT. Side effects includes mainly seizures due to the increase in the neurotransmitter levels, and anxiety, agitation, and irritability and insomnia. Developmental suicidal ideation is there. Hypertension is there. Contraindication is the seizure disorder patient. Extreme caution in patients with hepatic dysfunction. Then we go to varenicline. Varenicline is an alpha 4 beta 2 nicotinic acetylcholine partial agonist, which blocks the ability of the nicotine to activate the alpha 4 beta 2 receptors and stimulate the dopaminergic receptors, and significantly lower level than the nicotine. It replaces the nicotine in the nicotine acetylcholine receptors and produces the same effect and believed to give the same reinforcement and reward experience with the smoking. Varenicline also binds with more affinity to 5-HT3 serotonin receptors also. The dosing, patient should be started while the patient is still smoking, and the target quit date is fixed within the 2 weeks of treatment, as similar as bupropion. Dosing is first 3 days, 0.5 milligram OD dose, and next 4 to 7 days, it's a 0.5 milligram BD dose. From the 8th day onwards, it will be 1 milligram twice daily BD dose, and the initial therapy should be given for at least 12 weeks, and the optimal maintenance therapy is needed for another 12 weeks. Side effects includes nausea, insomnia, unusual or vivid dreams, constipation, headaches, depression, and again suicidal ideation. Thank you.